morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Swaminathan Iyer from MD Anderson Cancer Center, Houston, Texas. And he's going to lecture us on an update on T-cell lymphoma. This webinar is brought to you by Mumbai Hematology Group, supported by RPG Life Sciences Limited, and managed by Perfect Square. I thank Mr. Ajit Mulle, Mr. Sudhir Ambekar and the team RPG Life Sciences, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. Swaminathan Iyer from Houston, Texas, all our discussants who are themselves eminent hematologists and medical oncologists, and you participants who are sparing the Saturday evening, morning, and afternoon. Tomorrow, that is Sunday, 29th of October, 2023, from 11:30 a.m. Indian Standard Time onwards, we have a webinar on management of anemia in low-risk MDS by our guest speaker, Dr. Maria Diaz Campello from Spain. Let me introduce our discussants for the day, and here displayed in alphabetical order. To start with, we have Dr. Abhijit Baheti from Dinanath Mangeshkar Hospital, Pune, Dr. Aditya Jandial from Homi Baba Cancer Hospital and Research Center, Molanpur, Punjab, Dr. Amit Galgali from HCG, Bengaluru, Colonel Dr. Ashok Meshram from INHS Aswini Kolaba, Mumbai, Dr. Fahima Hassan from United Institute of Medical Sciences, Prayagraj, Dr. Gopinathan M. from MGM Healthcare, Chennai, Dr. Karthika V. Senthil from Dharan Cancer Specialty Center, Salem, Colonel Dr. Kundan Mishra from Kaman Hospital, Lucknow, Dr. Nilesh Jain from Balco Medical Center, Raipur, Dr. Reshma Roshan from Sher-e Kashmir Institute of Medical Sciences, KIMS, Srinagar, Jammu and Kashmir, Dr. Mohammad Rizwan Sheikh from Max Super Specialty Hospital, Saket, Delhi, Dr. Sitharam Anandram from St. John's Medical College Hospital, Bengaluru, Dr. Sudhir Kumar Atri from Pandit Bhagwat Dayal Sharma PGIMS, Rohtak, Haryana. Now it's a time to introduce our guest speaker for the day. We have with us Dr. Swaminathan Iyer from MD Anderson Cancer Center, Houston, Texas. And he's going to lecture us today on an update on T-cell lymphoma. Dr. Swaminathan Iyer is a professor of medicine at the University of Texas at MD Anderson Cancer Center, Houston, Texas, as a lymphoma specialist. He is an internationally recognized expert in clinical trials for cancer with 2 FDA approvals in lymphoma and leukemia. He graduated from Bangalore Medical College, Rajiv Gandhi University of Health Sciences with a gold medal in pathology in the year 1994. His post-graduation include training at AIMS, Wayne State University and University of Miami, and is an American Board of Internal Medicine diplomate in internal medicine and hematology. In addition, he has a laboratory interest in aptamers, chimeric antigen receptor therapies, and machine learning approaches to predict biomarkers from whole slide images. At the University of Texas, MD Anderson, he leads a T-cell lymphoma program. This involves collaboration with a multidisciplinary team in several research areas, including clinical trials with novel agents and cellular therapies, epidemiology, risk factors, and new risk prediction models. The rarity of this disease requires collaborative efforts to translate treatment advances. As a last consortium of its kind, it could remove the preventable roadblocks to collect and evaluate such TCL subtype, which improves sample collection for genomic testing and enroll more and more patients in clinical trials. Furthermore, it will also accelerate the enrollment of newer therapies, including histone deacetylase inhibitor, EZH2 and H1 inhibitors, PI3 kinase inhibitors, SYK inhibitors, immune checkpoint inhibitors, CD47 blockers, and cellular therapies aimed at T-cell lymphomas. Dr. Iyer also serves as the president of the Indo-American Cancer Association with a goal of giving back services and care for cancer patients in India. He is also the recipient of several awards, to name a few: American Society of Clinical Oncology Young Investigator Award, Outstanding Physician Volunteer for the Leukemia Lymphoma Society, Virginia and Cochrane Presidential Scholar at the Houston Methodist, Who's and Who in Healthcare, American's Top Physician, 2007 Present Healthcare Network Excellence Award 2017 and 2022. His work has been supported by grants from American Cancer Society, Leukemia Lymphoma Society, and National Institute of Health and several industry partners. He enjoys mentoring high school and college students to get them towards the next generation of physician scientists. His Twitter handle is @bloodbites or Dr. Swami_Iyer. And today, he's going to lecture us on an update on T-cell lymphoma. Well, thank you so much. Over to you, Professor Dr. Iyer.
Thank you very much, Dr. Amit, for this very generous introduction. I don't think I can claim any of those things you just mentioned. I'm here to, as a warrior or a soldier, to try and help out T-cell lymphomas, which is the last frontier in lymphomas that need an improvement in outcomes. Obviously, I think you rightfully alluded, and this brings us to the beautiful picture of MD Anderson on a sunny day. And the only way we can accomplish this is this 5 rings that you see, the Olympic rings that have made it possible, because it's T-cell lymphoma is entirely a T-cell, is a multidisciplinary disease, needs dermatopathology along with hematopathology and stem cell transplant, radiation oncology, and several other scientists who can help us figure out what the problem is and how we can solve those. So this is a TCLG group in MD Anderson that meets every week to talk through our patients, and every patient is unique, and also try and come up with solutions. Let me advance my slides if it moves. Okay, good. These are my disclosures, which you see. And more importantly, I would like to thank the patients who participated in the clinical studies. Their indomitable perseverance and resilience have made it possible for us to understand the science and also offer them the help. So they're always going to be an eternal source of inspiration. And in some ways, we are going through this maze, and we'll find an end to this. One of the ways that we're doing that is by a 3-pronged approach of knowing that this lymphoma is a genomic disease, and there are parallel developments in sophistications of therapies such as small molecules, monoclonal antibodies, CAR-Ts, etc. And one of the most important realization is each patient's tumor is unique. I know as clinicians, we take each patient as unique. I think the tumor is also important as a roadmap for planning treatments. So this is the problem. The problem in T-cell lymphoma is this classification. In B-cell lymphomas, at least you have a classification that has a lot of nuances, and there is some understanding of the biology of the disease or the behavior of the disease. In T-cell lymphomas, not only is the biology so different and heterogeneous, but the manifestations are also so different, spanning from skin involvement to nodal involvement to outside of the nodes in areas other than the skin. So they're called extranodal, and also the leukemic manifestation. So this is a takeoff from the 2008 WHO, which classified this morphologically into 4 groups. And yet there are 30 entities that have been recognized by the WHO, including the WHO and the ICC from last year. And part of the problem is that not only is the biology different, you need to have a good pathologist to give you an idea. And for the most part, as hematologists, we perhaps spend time with the nodal variety, which we will we'll talk more about. But we also end up seeing a whole lot of cutaneous T-cell lymphomas. 2/3 of cutaneous T-cell lymphomas are mycosis fungoides, as you see here on the left-hand side of the panel. And then you have the leukemic varieties, such as the TLGLL, that we see very commonly. Perhaps many of them do not need treatment, but nevertheless, we do see them, and some of them have cytopenias that also require attention. But if you look at the nodal variety over the years, what used to be PTCL NOS, or from a mature T-cell neoplasm, peripheral T-cell lymphoma not otherwise specified, has been the default category. The first discovery of ALCL based on the ALK staining or the translocation 2-5 put that in a different basket. And then the angioblastic T-cell lymphoma was also clearly a different biology and also different clinical manifestation. So you had the 3 varieties, and today you can see that there are at least 10 different varieties in the nodal subtype of mature T-cell neoplasms. In the angioblastic T-cell lymphoma, you will see, and I'll show you data why follicular T-cell lymphoma and nodal PTCL should be grouped into one large category called T follicular helper phenotype. And then, of course, in the anaplastic large cell lymphoma, you have the ALK negatives. And then in the ALK negatives, you have the DISP22 with the IRF4 rearrangement. And finally, the peripheral T-cell lymphoma, not otherwise specified, is not just a vast basket of diagnosis. You can actually delineate molecularly at least 3 different varieties there. So the molecular developments have clearly put us in a position to start not just teasing the biology, but also trying to come up with solutions. And you'll see as a conclusion slide that this is a morphological view of the classification, and we should go to a functional and a working view of the classification that as clinicians will help us identify those patients upfront and give the right therapies. So this is the task at hand. If you look at the overall survival, it is pretty dismal. I don't have to point out the survival curves for the PTCL frontline. This is from the International T-cell Lymphoma Project from 2008. Dr. Julie Vos and Jim Armitage put this together, and nothing much has changed over the years, perhaps for ALCL. The Echelon 2, which we will also talk about, has helped push this curve for the ALCL ALK negative towards ALK positives. And you can always question whether ALK positives have made a huge difference, but clearly the ALK positives do really well, and even sometimes better than diffuse large B-cell lymphomas. ALK negatives have made a huge difference in the survival curves. They move to the top, and the others still remain where they are. The median survival is about 1.5 years, and it's pretty dismal. And if you look at some of the subtypes, ATLL has the median survival in months. TPLL has a median survival in months, both in terms of PFS and also overall survival. And for those patients who do relapse, eventually, once they get the frontline treatment, whatever the choice is, the median survival for the PTCL first relapse is, again, months. So this is very poor. It's almost like lung cancer, as our oncology colleagues treat. And so we need to make progress. Part of the problem is the numbers are so small. At least in the US, there are about 10,000 new diagnoses every year. And you split in 30 different ways. Then you have maybe 300 here, maybe a 600 there, and to trying to put them on a clinical study and trying to collect samples is always a problem. So it's one of the efforts in MD Anderson is to try and see how we can enhance that and how to improve that process. And just a word on the cutaneous T-cell lymphomas. Cutaneous T-cell lymphoma is again a multidisciplinary disease, and we are very fortunate to have the work done by Dr. Madeleine Duick, who has really created a platform and also the roadmap for to manage MF. And one of the things with MF, unlike other lymphomas, is that it is one of the 2 lymphomas that have a TNM classification. Your AJCC, American Joint Commission on Cancer classification system. T stands for the tumor characteristics, the N for the nodes, and M for the metastasis. So this is one of the 2 exceptions. The other one is BIA-ALCL, which is probably not so common in India and some parts of the world, but in the US, I think we do see, and we are the largest collection of BIA-ALCL biology here. And one of the things that was found in the TNM classification, the T stands for the tumor itself in the skin, is based on the BSA area. 10% or less, it defines T1 and T2. If it's tumor stage, which means that the lesions are protruding outside the skin for at least 1.5 centimeters, is T3. Or if there is skin involvement more than 80%, is T4. And if you just use the T systems and combine that with the nodal systems, you have the stages. The stages 1 and all the way up to 2A do very well with the cutaneous T-cell lymphomas. It's the 2Bs and above that have a very poor prognosis. And as you can see in the risk of progression, it's pretty high. When you have a T3 already or in a stage 2B category, these patients have a higher risk of relapse. And when you further categorize this by adding other risk features such as the stage, the age, the LDH, and also the large cell transformation. So these MF essentially are small to medium-sized mature T cell. Sometimes they get larger. That's called large cell transformation. You can see that the survival actually drops. So this, and the reason I mention this is because many times we as hematologists see the extreme end of this patients with advanced stage disease, and they're classified as PTCL. And you have to know that this is not PTCL. The behavior is essentially that of an MF, which may be transformed otherwise. And so your treatments have to be directed to the cutaneous component and also to the nodal component. That being said, this has been the treatment paradigm for T-cell lymphomas. And we started to make progress when we realized that CD30 could target ALCL, and not just ALCL, any T-cell lymphomas that have CD30 expression. And if you have things such as the NK T-cell lymphomas, such as extranodal, L-asparaginase-based combination chemotherapy and radiation has made a huge difference in early stage NK T-cell lymphoma, and perhaps to a large extent even in the advanced stage disease. Then you have the anti-PD-1 therapies, which have made an impact. It remains to be seen whether these drugs actually get approved in this setting. And this is a disease that's more common in China, Korea, and Taiwan, and it's very likely going to see an approval there before we see it in the United States. And finally, ATLL is common in certain areas of the world, Japan and the Caribbean, and immunotherapy for with anti-CCR4 antibody has been the first approval, which made some progress. Today, we also have the EZH1, EZH2 inhibitor called valemetostat, which has been approved in ATLL. One of the surprising findings here in MD Anderson that I've seen is that we think that the ATLL is just restricted to the Caribbean and Japanese population, but it's not the case. We have the whole of South America, which probably have a huge wave of migration from, particularly in Peru, and Brazil has a huge population of ATLL, and also India. We have seen patients from India who live in the United States have had ATLL. It's a small percentage, but it's probably the tip of the iceberg, and we don't know what the predilections are. And I've also spoken to in discussions about patients where we have seen the HTLV1 manifestation. So it's important. One of the take-home messages from this slide is that for everybody with T-cell lymphomas, you would at least order an HTLV1 serology and an EBV by PCR, because these are two viruses that play a very important role in many of the subtypes of T-cell lymphomas. So, and the PTCL prognostic characteristics, if you look at these numbers on the top, they just give you the same thing that I mentioned earlier. But if you compare this with the at the bottom with the diffuse large B-cell lymphoma cohort, obviously the R-CHOPs have made a huge difference, and even there we're trying to improve that using polatuzumab and bringing CAR-T up front based on the risk stratified approaches. And you can see the progress that is made is essentially because of Rituxan to a large extent, and now because of CAR-Ts and other targeted therapies, I'm trying to move the curve as much as possible. But in T-cell lymphomas, one of the big problems is that we don't have that rituximab that can be universally applied. And you'll see that that's changing. And at least in one situation when CD30 is positive, those curves are moved up, particularly the ones in ALK-negative ALCLs. So there's a whole list of clinical problems that need to be addressed in T-cell lymphoma. I'm not going to go through this list. Each subtype has its problems, and each the overall category has its own problem and how to address this, including genomics. I want to talk about just one problem in T-cell lymphomas. About 20% of T-cell lymphomas, when they have this poor survival, why do they die? And the main reason is because they have this activation of cytokines to a large extent. It's a cytokine storm-driven disease by macrophages and T cells. So there's hypercytokinemia. There's a trigger in the T cells that cannot be stopped, and that manifests itself as secondary hemophagocytic lymphohistiocytosis. And we have struggled with this because there is no diagnostic criteria in the lymphoma category. So many years ago, Dr. Adi Lorenz, who is a fellow at the University of Cincinnati, along with Michael Jordan, and us, with Dr. Naval Davar, we put together a whole bunch of biology, both hematological malignancies and leukemia and lymphoma, and found that you don't need the HLH-04 criteria. All you need are two things, which is the soluble CD25 and the ferritin. Just based on this, we came up with this OHI, or optimized hematological inflammatory index. And that's good for diagnosis and good for prognosis. You do not need to do a bone marrow to show that there's hemophagocytosis. Why? Because the sensitivity is pretty low. for that, and along with several other things, including fibrinogen and triglycerides, you can perhaps capture these cytokine storm very early on, and we can make possibly an impact. Why? Because patients, when they do have a cytokine storm, should at least get etoposide, because etoposide improves survival. And as I mentioned earlier, there's no biologic like Rituxan. That's why the paradigm that when you treat the lymphoma, the HLH goes away is wrong in T-cell lymphoma. Whereas it's true in B non-Hodgkin's lymphoma with HLH, your PFS and OS improves. In T, NK, NHL, that is not the case. And we now are making progress. Dr. Abhi Maiti and MD Anderson is now leading a study with a pan-SIRP, SIRP, antibody, which perhaps could be that biologic that's going to make a difference in HLH. I won't mention more about this, but just to go back to the lymphomas and where the treatments and the frontline treatment approaches. And since we already saw this heterogeneity, it's a little bit of a mess. Not everybody should combination chemotherapy, definitely not the cutaneous varieties, even if they are nodal T-cell lymphomas, because the outcomes are pretty poor if they get chemotherapy. So that's why in the center list that you actually see, mycosis fungoides, etc., you have a reason not to use CHOP like chemotherapy, which has been the default from B-cell lymphomas. In extranodal NK T-cell lymphoma, anti-prolymphocytic leukemia, adriamycin does not work, and so you have to use a non-anthracycline-based approach. Obviously, for ALCLs, you always end up using a CHOP-based approach, and for the other varieties that are nodal, CHOP variations are important. And we have asked this question again, is there an R-CHOP for T-cell lymphoma? And it's not for lack of trying. You can see that romidepsin is the recent combination that failed in a phase 3 study. We will talk about that maybe for a few seconds. Possibly because of the way the study was designed, it took many years to conduct, mainly a European study, even though now the follow-up data, for those of you who have seen the Lugano, there is actually an overall survival in patients with a TFH subtype. What does that tell us? That romidepsin, which is a HDAC inhibitor, plays an important role in changing the epigenetic signatures. And now we know the TFH subtypes predominantly have an epigenetic signatures. And if you had designed the study in a different way, perhaps romidepsin CHOP would have been a positive study if that study population was enriched for TFH. And the other agents that have been looked at, lenalidomide in CHOP, alemtuzumab in CHOP, high responses, but lots of toxicities. And so there's no difference in the overall survival. Etoposide in the retrospective review has shown that it does add to the overall survival. But as I mentioned, clearly in patients with cytokine storm, it helps. And I think you won't always consider CHOEP. And that's, if we don't have any clinical study in MD Anderson, CHOEP is the standard approach that we use for our patients and not CHOP. And now there are ongoing studies with azacitidine and PI3K inhibitors with the intergroup study, and you will hear more about that in the frontline setting. So these are all the survival curves. I don't have to belabor the point, just to show that if you look at all the combinations since the 1990s, all the way up to this romidepsin CHOP, clearly there's no impact for adding the biologic. And perhaps it's the patient selection here. And the etoposide, this is the Golem study, which is a retrospective study showing that etoposide perhaps does add to the overall survival, but then it's retrospective. There's been no prospective studies. And this might be a question that can be that's likely answered in the intergroup's ongoing study with the PI3 kinase inhibitor and with the azacitidine and with the CHOP or CHOEP and the standard arm. So it remains to be seen. So one of the other paradigms in T-cell lymphoma is, while you use a CHOP or a CHOEP-based approach for nodal T-cell lymphomas, how can we maintain the response? You already saw that the PFS is pretty poor and the median overall survival is about 1.5 years. So this is one of the first studies with Dr. Diamore and his colleagues that showed that for those with chemosensitive disease and young patients, intensification is the way to go, because you do improve the 5-year overall survival. As you can see here, it's about 51%, which means half the patients who go on to get this therapy do have a long-term response. And we have that experience as well. Of course, if you look at the subtypes, perhaps you see many of these patients have ALK negative ALCL. And if you look at the NOS and the EATL, you may not see the impact. But nevertheless, I think you have to consider this. Even in our E2 study, which I'll show you, there has been a trend towards overall survival in these patients. And our own data from MD Anderson, this is AITL patients, about 250 patients. Dr. Samir Sroor looked at this and found that just in the AITL alone, for the transplant upfront, the 3-year overall survival, and no transplant is 19%. And if you decide to hold the transplant and do it later in the second line setting, the stem cell transplant and relapse is 0%. So in other words, there's good reason for us to believe that the intensification has to be done upfront in CR1 and not in CR2 or subsequently, because they don't have a response. The problem, of course, is that the CHOP or the CHOEP or any clinical study should give you a complete response, because if you don't achieve a CR, then you can't take them to a transplant, because no CR is perhaps about 37%. In some patients, maybe there's a role for allogeneic transplantation. You can see on the right-hand side, this is Dr. Sony Smith's data showing that allo and autos from the CRBMTR registry didn't make a difference in overall survival, partly because of the graft-versus-host disease. Mind you, this is data from old times, and now the management of post-allo transplant patients have improved. And so for select patient population, I think allo transplant is definitely a possibility, especially for young patients. And there are certain subtypes such as TPLL, ATLL, gamma delta hepatosplenic T-cell lymphomas, where allogeneic transplantation should be the treatment of choice. The other subtype is the large cell transformation. And for some of the nodal varieties, particularly when patients don't achieve a CR, if you can get them close to a CR, perhaps an allogeneic transplantation is the best way to go. So the CD30 has the line in the sand that has been drawn, at least in T-cell lymphoma, that's made a huge difference, and it's a biologic. About 50 to 60% of T-cell lymphomas express CD30. And as you know, the developmental history of brentuximab, which is my mentor's monoclonal antibody from University of Miami, and eventually just conjugated with the linker, and the linker here is the MMAE, the auristatin, and made a huge difference. So this is the line based on the Echelon-2 data, where patients were compared to either CHOP or a CHP plus BV. And and you can see that the endpoint here was PFS and overall survival. So this is the only randomized study in T-cell lymphoma which not only met its primary endpoint of PFS, but also its secondary endpoint of overall survival. So it made a huge difference. The caveat here is there is an enrichment of ALCLs. So the requirement from the European agency was that 70% of these patients need to have ALCL, whether it's ALK positive or ALK negative. About 30% were other subtypes. And clearly this overall survival and PFS was driven by ALCL, particularly the ALK negative ALCLs. And you can see that the overall survival is not was maintained. And even we have an update at ASH this year showing the PET data. And in this case, the PET was done after 4 cycles. And clearly PET was predictive of response, both for the CHOP category and also for the CHP-BV category. And one of the things that came out of the Echelon-2 is that Kerry Savage did was to look at the intensification, and clearly the intensification made a difference. There's a trend towards overall survival in both non-ALCL and also the ALCL ALK negative patients. Even though we could not determine the molecular subtypes, I think our tendency today is to still consider the patient for an upfront transplantation if the patient is eligible, maintains CR, and as a young patient. So the other variation of this is data that Herrera presented, and we were part of that investigator-initiated study that he started, which is addition of etoposide and adding stem cell transplantation and brentuximab maintenance. And this design was that patients would not just get CHP-BV, but also get etoposide for up to 6 cycles. And if they're eligible for a transplant, get an autologous transplant, and get BV for at least 10 cycles. And mind you, majority of these patients were non-ALCL patients. This started at the time that the BV was not approved in the frontline setting as yet. And you can see the CD30 expression was all the way down to 9%. The Echelon-2, the CD30 expression was 10% or greater. And you can see that 2/3 were 10% or greater, but you had many patients where the expression was less than 10%. And also had patients with high risk categories. And what is the summary? And I want to put this in the context of Echelon-2. Clearly, what it showed is that it made a difference in the PFS. Of course, it's a single-arm study. But if it is feasible, you could take them to add etoposide, take them to transplant, and also do BV maintenance. And we have a manuscript ready, pending. But clearly, I wanted to show you that when you compare the PTCL-NOS categories of Echelon 2 versus our cohort of CHEP-BV, it seemed appeared to be better. Of course, you're comparing apples to oranges. On the top are the two PTCL-NOS and AITL from the Echelon 2. And at the bottom, you have the CHEP-BV, and the follow-up with the survivors about 1 month. One of the questions in Echelon 2, particularly in AITL, is that it didn't seem to make a huge difference by adding brentuximab. There was a difference between the two arms, but the numbers are too to compare. If you look at 29 patients and 43 patients. Here, clearly, there seems to be the advantage of adding etoposide and also doing brentuximab maintenance. We've completed the first cohort. We're doing the second cohort of another 40 patients just in the non-ALCLs, just as a validation point. So stay tuned for this. So for those patients who can get etoposide and can get brentuximab maintenance with stem cell transplant consolidation, is perhaps the best bang for the buck. And you can see we have many patients who are still alive by using this strategy. And this is the overall survival. You can see the overall survival in the non-ALCL seems to be much better in the bottom right-hand panel compared to the Echelon 2 cohorts. That being said, the frontline approaches is whenever you can use BV, and we now have data which I'll be presenting tomorrow. And we've done a study for less than 1% CD30, which means negative CD30. And the EHA data actually shows that the responses are pretty high, though we don't have a long-term follow-up. So BV seems to be a good frontline approach, no matter what the CD30 expression is. And then you have a potential role for etoposide in those patients with high risk. And then consolidation needs to be important. The role of maintenance is there is data. And I think for the right patient, I think the maintenance is definitely a possibility. So these are some of the mature T-cell lymphoma frontline pathways, not just in nodal T-cell lymphomas, but also in the others. If you take the same set of category and divide them into CD30 positive and CD30 negative, you have these options. But for the CD30, we have a huge problem because we think that other than BV, perhaps therapies that have been tested like lenalidomide have not worked. And perhaps this is where the role of azacitidine, midepsin, and belinostat in combination with CHOP or CHOEP-like approaches could make a difference for the nodal AITL and the TFH subtypes. So how is the advances in biology? And this is where I think we can peel off the surface, not just looking at the morphology, but trying to understand the intricacies of the biology. And if you look at the pathologists, it's easy for many pathologists to look at ALCL. As I said, that is one of the first pathologies that is delineated based on this morphology, the horseshoe-shaped nuclei, and then you have the ALK positivity and the CD30 positivity. The AITL can also be delineated when it's very clear based on the small to medium-sized cells, the blood vessels, the immunoblasts, the dendritic cell meshwork, and the TFH markers such as PD-1 and the EBER expression in the B cells. Everything else was relegated to the not otherwise specified category. But what do we do? What do we know now is Dr. Javed Iqbal, who is from Srinagar originally. He and his team from Nebraska, along with Dr. Julie Woes, set forth with this idea that we could, with the gene expression signatures, delineate the biology. So this is the left-hand side picture showing the gene expression profile for various subtypes. On the right-hand side, what we actually found that there is a discordance. What we thought was an AITL was very clear genomically for the most part. And there are about 20% of patients that would not fit the category and was actually classified as PTCL-NOS. But if you look at the genomic signature, it's actually an AITL. And similarly with ATLL, there's a small percentage and about 10% for ALCL. So what that means is that molecular signature, if you have a certain subtype of a profile, particularly the epigenetic signature, which otherwise what looks like a PTCL, should be reclassified as a T follicular helper phenotype. Why? Because those patients don't necessarily benefit from many of the therapies that we just talked about, and perhaps using the HTAC approach or the DNMT3 approach, inhibition approaches should be the way to go for these patients. Obviously for ATLL, there's no standard therapy, and we have to follow what the Japanese have done. ALCL, it's not been a problem because we have the brentuximab. Furthermore, in the PTCL NOS, what we thought as one wastebasket category, Javeed actually pulled out 3 different groups based on the biology. The one was the TH, which is called the TBX21 on the left-hand side, and the GATA3 or the TH2 type. And then you have the ones in green, which is the unclassifiable. Why is that very important is that the TBX21, the blue curve, survival curve that you see here, do better than the GATA3. And the GATA3 patients with PTCL NOS don't do as well. And that's driven by the biology. The GATA3s are driven by the MYC and the mTOR pathways and the PI3 kinase pathways. And clearly the median overall survival for this PTCL subtype is less than a year. For the TBX21, they do much better. They're not otherwise specified category. So it's important that we tease out this biology patients as well. And now today, how do we translate this into the immunohistochemistry era is to take this NOS and do look for the TBX21 and the GATA3. But it's not as straightforward approach like Hunt's criteria that we do in diffuse large B-cell lymphoma. You have to first go, you have to do this in a stepwise fashion. Start with TBX21. If it's greater than 20%, then it is TBX21 type. If it is less than that, you have to then look for CXCR3. If CXCR3 is not greater than 20%, then you look for GATA3. If let's give you an example. If the patient has both TBX21 more than 20% and GATA3 is more than 50%, it's not GATA3 subtype, but it's actually a TBX21 subtype. So this is a simplified version. This is set up by Dr. Catalina Amador in Miami and Dr. Vega at MD Anderson. But you can see that this has helped simplify some of the approaches in the PTCL NOS. And we have started doing this in the last 3 years since this classification is set out. Of course, the landscape of somatic mutations is much larger. You can see this is the AITL, ALCL, and the PTCL NOS on the left-hand side. But you also have the other varieties like the gamma delta T-cell lymphomas, and then you have the metals, and then you have the other gamma delta varieties, including the NKT cell, which seem to cluster together. They all have a JAK-STAT mutation overexpression or a mutation. All also have certain tumor suppressor losses like SET-D2. So in these patients, I think you need to have a completely different strategy. And we are happy to show that there is a target for all these subtypes put together, even though they are rare. So they are the rare subtypes. It appears that CD94 is a common target, and we have an ongoing study with CD94, and you will see data very soon. We don't have a presentation at ASH, but clearly CD94 targeting of gamma delta T-cell lymphomas, and several of the metals and the gamma delta varieties could be approached that way in the future. And in MD Anderson, we have this roadmap, and we're still collecting data on many of our patients with the idea that we can genomically sequence them. And you'll see how it all comes together in the end and why we need a signature study in T-cell lymphoma. And finally, in the nodal T-cell lymphomas, the other variety is the AITL. And I mentioned to you earlier is Javeed Iqbal's work on trying to tease out the markers, which are predominantly epigenetic regulators such as TET2, DNMT3, and IDH2. And clearly, these have to be targeted both from the cell perspective and also from the microenvironment perspective. And if you look at these ongoing studies, romidepsin seems to have a better responses in AITL, and so does azacitidine, even though the phase 3 study, again, it goes with the study design. There was a phase 3 study that is designed by Dr. Francois Lemonnier from France, and look at comparing azacitidine with physician's best choice of bendamustine gemcitabine, and found that azacitidine did not improve the PFS. And you can say that the study was a negative study, but in reality, I think we are setting the bar too high. The median PFS, as I showed earlier, for PTCL relapses is not more than 5 months. In fact, it's anywhere between 3 to 5 months. So this study had a PFS of 12 months, which I think is a very ambitious goal. I think if you had moved the needle from 5 months to 6 months, it would have made a huge difference. But the secondary endpoint of overall survival was met. Those patients who received azacitidine compared to the best standard of care, which is chemotherapy, did much better in this situation. So clearly for TFH, I think the epigenetic markers like the CD30 perhaps is going to draw the line. The SWOG study is going to give us an answer. We also have an ongoing study that I'm leading, which is looking at belinostat CHOP with pralatrexate COP and CHOP. And it's a long, drawn-out study, and hopefully we'll have an answer sometime soon. And this is just to show you Dr. Jia Ruan's data from Cornell, that when you add azacitidine to the front line, you do have a high response rates. And this is the concept behind the SWOG study that is ongoing, led by Dr. Neha Mehta Shah. These are some of the details. I won't get into the details, but there is another aspect of AITL which is also important, and it's also true for other PTCLs, which is the microenvironment. As I mentioned, 20% of them do have this hypercytokinemia, but they have this undercurrents of a storm. Why? Because the microenvironment is always active. It's always like a volcano ready to take off. And it's because of macrophages and eosinophils and plasma cells. So how do we target those? We have some ideas. And one of the studies that we actually did was to combine checkpoint inhibitor with romidepsin in T-cell lymphomas. This is a single institution study. The best response rate is 47% with a CR of 37% in the intent to treat. But if you look at the evaluable cohort, the overall response rate is 71%. And this is the swimmer's plot. But clearly what we saw was the overall survival by subtype. The TFH subtype did much better. You see the blue line here on the top, that's a TFH. PTCL, NOS on the bottom, they didn't do as well. We didn't have problems with hyperprogression, but both OS and the PFS was very different, the TFH subtype. And this is something that we are starting to do off protocol. We also are collecting lots of data in these patients. And just an example of a patient with the BIA ALCL. So the other subtype that also responded was the ALCL patient. This is a patient with BIA ALCL, very advanced, got multiple treatments, including removal of the implants and capsulectomy. And you can see on the right-hand side, this undercurrents of cytokine storm. And the patient went on to receive pembrolizumab or numidepsin and went into complete remission. This is the only treatment that the patient responded to of the 6 different things that the patient had received earlier. So clearly there are responses seen. What we're trying to do is tease out the biology here by looking at the whole genome sequencing and also the whole slide images by using machine learning and deep learning approaches. And we actually have some data, which we won't be showing at ASH this year. We'll hopefully be able to present at EHA next year and some fascinating insights into the microenvironmental biology. Finally, I'm going to talk about CAR-Ts. And CAR-Ts have been a problem in T-cell lymphoma because some of the markers such as CD5 and CD7 are universal. So there's a concern for fratricide. Even though we think we are able to solve that problem, the focus has been on trying to look at the post-mature T-cell antigen such as CD30, CD37, and CD70. So what I'll show you is the data that I presented at EHA. CD70 is a ligand for CD27. And it appears to be very important in memory T cell and also for Tregs. In fact, if you don't have a CD70 or if you have CD27 mutation, you have consistent or you have a perennial EBV infection. And now these are the families that have been identified in the Middle East with CD27 mutation and CD70 loss, and also have HLH because of hypercytokinemia. And we have looked at CD70 expression in multiple different types, very high in CTCL, and also several subtypes of the T-cell lymphomas. So based on this approach of using CRISPR-Cas9, this company CRISPR that is developed by one of the ladies on the right-hand side, Dr. Emmanuelle Charpentier, the left-hand side is Dr. Jennifer Doudna. Both of them received the Nobel Prize for CRISPR. And so Emmanuelle Charpentier's company is CRISPR. We use the CRISPR approach to knock in the CD70 and take out the class 1. So this is a phase 1 study, the cobalt lymph study in patients with CD70 expressing T-cell malignancy. And more importantly, it's an allogeneic CAR. So it's easily prepared. It's off the shelf. And the time for patients to get onto this is very short. It's just a matter of a week. So they get a standard lymphodepleting chemotherapy, and we tested different dose levels. As you can see, the first data cut was 18 patients, and we had all the T-cell subtypes, such as the AITL, ALCL, including ATLL and CTCL patients. And the overall response rate is about 70%. Mind you, it's a small cohort, and along with the disease control rate of 90% in the CTCL. And you can see the waterfall plot at the bottom showing responses in all the compartments. And this is some of the examples of patients. This is a patient with transformed MF who failed brentuximab and came to see us. And these are tumor stage. You can see the coin at the abdominal wall. And within days after infusion, you can see that the tumor is starting to melt away with a dramatic response. And this patient went on to achieve almost CR, except for this lesion in the fibula. Unfortunately, when the protocol was written, he couldn't get a second dose of the infusion. Had disease control for at least 4 months before the disease relapsed again. This is another example of a patient with large cell transformation who had never responded for the last 4 years of various therapies, came in with his tumors and couldn't walk because of oozing lesions in the legs, as you can see, and an mSWAT of 84. And within a month, everything is gone. And the patient was able to walk, and you can see the PET scan showing a dramatic response. And so finally, I think it's important for us to realize that T-cell lymphoma, even though it is morphologically challenging, we need to tease out the biology. We need to look at the targets. So the right answer for a T-cell lymphoma is not just looking at morphology, but you have to look at the cell of origin. You have to look at the microenvironment and the kind of cytokines it's producing. Yes, and morphological label. And then the treatment options then become somewhat easier for us to tease out. It doesn't have to be chemo. It could be HTAC. It could be PI3 kinase inhibitor, or it could be CAR T therapy for the right patient. And definitely the brentuximab is still an option for many patients with CD30 positive T-cell lymphoma. So thanks to the moonshot effort at MD Anderson, we were able to unravel biology, thanks to Dr. Neelapu and Dr. Kadia, who are the co-leaders here. And we have several targets which are still undisclosed, which we're very excited about, which we'll be able to talk about very soon. And also the alignment with the long-term, there is the IDSO, and we now have inaugurated the TMC3, which allows us to tease this biology. So this is a summary slide to show the targetable pathways at MD Anderson. There's several options for upfront and also for the second line setting. In summary, T-cell lymphoma is heterogeneous, difficult to diagnose, poor outcomes, but it's very important that it's a multidisciplinary effort. We need to tease the biology, consider each patient as unique, and then you have to come up with solutions for these patients. I want to stop here by saying this is we have gone from the worst of times to the best of times. This is my patient with the CAR T. On the left-hand side, I told you that he couldn't walk. It was oozing. A month later, after the CAR T was given, you can see the lesions are gone. And the first thing he did was to go and buy the shoes so he could dance with his daughter. Now he's 2 years out and still remains in complete remission. So I'll stop here and thank you for your attention. This is the entire group that makes it possible for us to do these kinds of things at MD Anderson, and happy to entertain any questions. Thank you.
Thank you, Dr. Iyer, for the wonderful lecture. It was a brilliant update, I may say. Thank you for being over here today with us. And I now request our discussants to please put raising signs so that we can start question answer session with Dr. Iyer.
Can you hear me?
Yeah, Dr. Nilesh Jain, please go ahead.
Yes. So it's indeed a very wonderful lecture by Dr. Swami. So thanks for it. He has beautifully explained about the updates on T-cell lymphoma. So my question is, in any of the slides, I have not seen any role of venetoclax in like AITL or any experience on that.
Great question, Dr. Jain. I think venetoclax doesn't play a role in T-cell lymphoma, unfortunately. So that's one of the our moonshot questions that we have. Dr. Vega and Dr. Deepa Sampath are asking the question along with Dr. Kadia. It appears that the BH3 biology is very complex. The proteins that maintain the mitochondrial integrity. You have the BCL2, you have the BCL-XL, and you have the MCL1, etc. So venetoclax targets the BCL2 because it's a BH3 mimetic. And it does not play an important role because there are other pathways, perhaps MCL1, perhaps BCL-XL, which the venetoclax does not target. In fact, we have a study with we have taken a different approach. So how can you cut down the MCL1? MCL1 can be targeted, but the drugs are not safe. So we have taken the approach of trying to control the transcript. So we have a CDK9 inhibitor, which actually controls the transcripts. The first proteins that stop production is the MCL1. So that's an indirect way of controlling this. So unfortunately, venetoclax doesn't work. The only exception is TPLL. TPLL is the only exception where the venetoclax still maintains sensitivity. And so Dr. Kadia, who has several studies by combining venetoclax with other agents such as Jakafi with bendamustine. And so I hope that answers your question. So I wish we could use this, but that's the problem. Can't use venetoclax in this setting.
So thank you very much, sir. My second question is related to the stem cell transplant. So in these cases where basically the patient received the CHOEP-based therapy, like you mentioned, the 6-cycle sub-CHOEP and then followed by auto-SCT. So in auto-SCT, do you face any problem with the cell dose, like the optimal cell dose which is required to perform the autologous stem cell transplant? Because in our experience, we found that in these cases the cell dose is, I mean, it's suboptimal.
So I think the question is, it depends on what the patients get and how many therapies the patients get.
Yeah.
So typically the front lines and CR1, generally the collection has not been a problem. We have not had a problem with getting patients to an autologous transplant. Sometimes we do have a problem with allotransplant, particularly if they get CAMPAT. T-cell chimerism is a problem. And it's a problem in TPLL and several other subtypes where you end up using CAMPAT. But for an auto, I don't think we've had a problem. Obviously, when you use agents like bendamustine and bendamustine BV, I didn't talk about it, but it's been used in the relapse setting. There, we sometimes encounter a problem with collection, and sometimes we have to redo this. What our transplant colleagues, Dr. Hosing and Dr. Nieto, do is that they actually treat them with IE. Instead of ICE, they give IE and collect off chemotherapy, and it appears that that has a much better yield for T-cell lymphoma.
Thank you very much, sir.
Certainly.
Thank you, Dr. Nilesh Jain. Dr. Gopinathan, your question.
Good evening, sir. Thanks for the thought-provoking lecture. We could hear that there are many mutations which are epigenetic modifier-defining mutations in T-cell lymphomas. But my doubt is in that case, why azacitidine is still not translated into a clinical benefit?
Oh yeah, as I told you, partly. I mean, it is. It's not that it's not a good treatment choice. There's a ROMI-AZA, which I didn't talk about. It's an ongoing study. The smaller studies, it was a single agent azacitidine, oral azacitidine, and the combination of oral AZA with CHOP have shown the benefits. So now we have to do confirmatory studies, right? So the confirmatory study in the relapsed refractory setting, unfortunately, it is a study design, I would say, more than the drug itself, because the PFS for that study was pegged at 12 months improvement from 5 months. And what is the result of that randomized study? The PFS went from 5 months to 5.1 months. So in other words, I think we have to know we have to have realistic expectations, and that's part of the reason why. But if you look at the overall survival, those patients who got oral AZA compared to any chemotherapy, clearly there was a difference in overall survival by about 4 months. So it all depends on the study design, and I think AZA still has a role to play, and future studies will tell us that.
Thank you, sir. Post-transplant relapse in a case of, post-allogenic transplant relapse in a case of T lymphoblastic lymphoma. So in these kind of cases, what should be the strategy ahead, sir?
That's a good question. So we didn't talk about T lymphoblastic lymphoma, even though it's not a mature T cell. There are, I mean, it sort of falls right in the gray area, right? So and especially if they have mature T cell features, right? So except for TDT, maybe. I think some of these patients, we do combination chemotherapy. But what the approaches that we have taken, this is something Dr. Nitin Jain's area. So you can see there's a super specialization in even the subtypes. So he has taken the approach of coming up with novel combinations. Some of the combinations are Velcade, even AZA and ROMI. I think there have been some approaches. But we also are looking at CAR-Ts, CD7 CAR-T. The expression of CD7 is pretty high in lymphoblastic lymphomas, unlike in mature T-cell lymphomas where the first antigen to be lost is CD7, so your CD7 expression goes down. So CD7 CAR T seem to make a big difference. Even data from China shows that CD7 CAR T, and they're now trying to incorporate the CAR T along with the allogeneic transplantation in those patients. So if, of course, in real world, what do you do in this situation is to give them combination chemotherapies. If they have not received hyper-CVAD type approaches, that's something that you would take. L-asparagine based approaches is what you would take. So right now, there's no standard of care. If you can send them to clinical studies, ideal, but I think combination chemotherapies and try and get them to a second transplant. So that's sort of the goal in the real world setting.
Okay. Thank you, Dr. Gopinathan. Dr. Mohammed Rizwan Sheikh, your question, please.
Evening, Dr. Swami. Really nice presentation and a lot of learning there for us. I just wanted to ask, like, how do you approach a relapsed NK T-cell lymphoma? Because we see quite a few cases here, especially the ones which presented stage 4 disease. It's very difficult to get them into remission. And in the frontline setting, do you consider auto versus allo, or in the relapse setting, what is your approach?
Yeah, great questions. So stage 4 disease is a problem for NK T-cell lymphomas. The response rates are not as high, and there's no cure, potentially cure. I mean, you are able to cure maybe about 30% of these patients. So the frontline approach, if you have used L-asparagine based approach like SMILE or DDGP, which is the GDP with the addition of L-asparagine or PEG-asparaginase, then potentially we would take them to an allo transplant for the young patient. So that's another exception. Lean towards doing an allo versus an auto, and maybe situations where the patient is older. It's not the issue of not finding a match. An auto can also be a consideration for these patients, but you would want to do it upfront. And particularly if they have HLH, as you know, about 10% of NK T-cell lymphomas, advanced stage, do also have HLH. I think allogeneic transplantation is the best way to go. Relapse NK T-cell lymphoma, that's a huge problem. So we've looked at checkpoint approaches. The sugamelimab is one of the agents that's a PD-L1 inhibitor that seems to have shown a response rate. Even there, the Koreans have actually shown very good understanding of the biology. It appears that they have a Treg-like signature. The anti-PD-1 therapies do not work. Initial responses were in the 60% range, but if you tease out who responds and who doesn't respond, it appears that if they have Treg signatures, there's no point in giving them a checkpoint inhibitor. And that can be easily found out by looking at FOXP3 by immunohistochemistry. But so if you use a PD-1 like inhibitor, but you can also combine them with chemotherapy. So chemo with pembrolizumab. And I really think that there is no standard approach that's can be considered. But if you use a Hodgkin's type chemo pembro combination, I think that's reasonable. Pembro alone may not be sufficient in this particular setting. So a checkpoint inhibitor with the possibility of combining with chemotherapy. The other thing to keep in mind, about 40% of NK T-cell lymphomas actually show CD30 expression. So not to forget that you can use brentuximab in these patients. So you can go that route as well and combine that with chemotherapy. So you have different ways of treating these patients. But I agree with you. Sometimes it can be a challenge, and we won't be able to get them into complete remission. And then these are the patients that don't do well.
Thank you so much.
Thank you, Dr. Rizwan Sheikh. Dr. Ashar, the question, please.
Hi, sorry, it is actually Dr. Reshma here. I just got disconnected and the name came as Ashir. So thank you so much, Dr. Iyer, for your presentation. So my question is, if the hepatosplenic T-cell lymphoma and you don't respond to CHOEP, what is the next line in our setting where we don't have clinical trials?
Right. So I'll just take a step back. We don't use CHOEP for gamma delta hypersplenic T-cell lymphomas. So the approaches have been to use EPOC based approach or a hyper-CVAD based approach. And even in our own data set, I don't think there's one better than the other. Patients have done well with EPOC. Patients have done well with hyper-CVAD based approach, or even the non-anthracycline. I think the general theme there out in the literature is that somehow they're anthracycline resistant, which is not true. But the only way to prove that is by actually showing a head-to-head study, which we cannot do in gamma delta hyperdisplaying T-cell lymphoma. So these patients, when they do relapse, I think you want to, in some ways, if they don't respond to CHOEP, then you go to a gemcitabine-based approach. So our go-to has been to use gemcitabine, etoposide, and there was this old SWOG study with PEGs. Dr. Daruka Mahadevan led that study many years ago. It was published in JCO, and it had a 40% response rate. So it was a frontline study, but potentially you can think of combining PEGs. So what is PEGs? PEGs is gemcitabine, etoposide, and PEG asparaginase along with steroids. I think so. That's a potential combination you could consider in the real world setting for the relapsed refractory gamma delta hyperdisplaying T-cell lymphomas. The other thing to consider also, and I think I'm sure you would send many of these patients to transplant, and we've had patients with lower volume disease to consider just Jakafi and Campat. And we've treated many patients with Jakafi and Campat. We've also treated patients with Gemox and Jakafi. So these are the three different options in the real world setting you can use. Of course, as I told you, it's a study which has CD94 as a marker. And so we would consider them for the CD94 monoclonal antibody study, which is by Dren Bio. And very soon we'll also have a CD94 CAR T as well.
Any other question, Dr. Reshma?
No, the continuation of the same. This patient got diagnosed after the splenectomy. Does it change the prognosis if we have to treat patients?
I don't think so. It only reduces the burden of the disease. I don't think splenectomy has changed the course in her gamma delta. We end up seeing many patients who get diagnosed outside. The only way they can diagnose is by taking the spleen out, which sometimes helps manage the disease burden, but I don't think it changes the biology. You still need to consider chemotherapy because there's disease hiding in the liver, there's disease in the bone marrow, and sometimes in several other areas which are an extranodal. So I think you have to treat them the same way you treat any other gamma delta T-cell lymphoma.
Thank you, Dr. So much.
Welcome.
Dr. Reshma. Dr. Agarwal, sir, your question.
Hi. First of all, thank you very much for being with us again, and wonderful talk. A lot of nice questions in the session. I have some very simple questions. In India, we have a lot of patients with T-cell hyperplasia. We find that in that ocean of reactive T-cell hyperplasia, the diagnosis of T-cell lymphoma gets lost. Even the quality of gene rearrangement studies is not up to the mark. And retrospectively, after a few months and sometime a year, you come to know that you have made a mistake on either side. Any recommendations on this front for developing work?
First of all, Dr. Agarwal, thank you so much for the invitation, and congratulations to you. And you've created this whole platform for educations, and that's phenomenal. And it's so engaging, and it's very interactive. So thank you very much for that. Your question on the T-cell hyperplasia, it is a problem even in the US. And part of the problem is because how those biopsies are done, and sometimes you don't get sufficient material, especially in the US. One of the problems is that they end up doing a needle biopsy, which is, a problematic to identify the biology. You need a good architecture for TFH or for making sure it's not PTCL-NOS. So that's one of the problems. The second problem is that you do have hyperplasia for lots of reasons. I mean, you could have viral mediated, or it could be even some kind of an idiopathic process driven by some kind of chronic inflammation, and also medications. So how do you tease that out? I think finally it's the clinical pathologic diagnosis. And we've made it a point, and we always emphasize this, the thing, the clinician should talk to the pathologist should talk to the clinician, and provide as much information as possible. I can tell you in our own TL is a case in point. I mean, and also MF. Those are two examples where patients show up with atypical lymphoid infiltrate, and so or T-cell hyperplasia, right? So how do you identify this? Old timers just call it pathologists call it atypical lymphoid hyperplasia. So we push them to do immunohistochemistry. We push them to help us delineate the clonal markers, and including flow cytometry in the nodal setting, which sometimes can be a tricky process. So these are some of the ways that I think we can do it. And genomics help. Even in our discussions, we say that we do TCR alpha, TCR beta, and TCR delta. To some extent, they help, but clonality doesn't really change this diagnosis. You can even have a clonal process from diagnosis. I can give you an example of a patient I saw some time ago, presented with a cytokine storm, hyponatremia, and had splenomegaly, but was on Cellular or changed his medication for psoriatic arthritis. And he had a wave of 30% of his cells in his peripheral blood and bone marrow were gamma delta T cells. It took almost 2 weeks for a pathologist to go through this, and finally we treated him like a T-cell lymphoma with the first cycle, but it turned out that he had a very profound gamma delta T-cell reaction to the treatment he received. And when he went back to the TNF inhibitors, he's totally fine now, 5 years later. So I think the context is also important, and I totally agree with you that it's a collaboration and as much information that we can provide each other.
Thank you. My other question is, when Campath was very easily available, we did use it quite a bit in this situation because there was nothing much available. What's the situation of Campath today?
It's still available. It's a named patient program, so you can write a Sanofi, and it's actually not that bad. It's managed by a third-party vendor, and you go online and request the drug, and it asks you for the indication. They send you a free drug. So even for us, it's a free drug. So for TPLL, the Campath supplies, they're all free for our patients. And for a gamma delta hyperosmotic T-cell lymphoma, we use Campath. Occasionally, we use Campath in large cell transformation and some other subtypes. The problem with Campath, as you know, Dr. Agarwal, is the risk of infections, and we're considering allogeneic transplantation, also chimerism. So we've seen, Dr. Hosing is always concerned about our patients. They all invariably have very poor T-cell chimerism, and it's anywhere between 0 and 20% for patients who get Campath. So if you're considering allogeneic transplantation. So one of the other strategies that we've been doing is, instead of doing 16 weeks, instead of doing 12 weeks, maybe get them to a very good response, limit the amount of Campath that is used, use other approaches like Jakafi and things like that, so to improve the chances of post-allo chimerism. So Campath is available. I think you just have to, there is a website. I'm happy to email you that link for you to use.
Right. The other question was, is there a place for purine analogs?
Yeah, definitely. I think purine analogs we have shied away from for all these years, whether it's fludarabine, pentostatin. Of course, gemcitabine is very commonly used in the setting as an antimetabolite, sort of, and bendamustine. So if you look at those, you tweak those molecules, there is a role for those. Fludarabine is definitely a treatment for patients undergoing CAR-T. You know, the questions that comes up as a lymphodepletion therapy is does it actually help treat this? And we have seen this. We have seen, whether it's ATLL, whether it's a large cell transformation, that it seems to regress the lesions. So there might be a role. And if you go back to the old literature, when nothing else is available, we've used fludarabine, we've used pentostatin. I think that is definitely a consideration if you don't have anything else, if you run out of options. So use a flu-cy approach. I think it's still reasonable. If they still have a marrow reserve, I think that's, in lieu of anything else that is not available.
And in TFH lymphomas, where do you put the immunomodulators?
Great question. I think that we didn't talk about immunomodulators, and one of the problems is that so we've talked about checkpoint inhibitors, and clearly there's a role for immune modulation. Lenalidomides also seem to have shown some response. The Revel study from France actually showed response, but was poor tolerability when you combine it with chemotherapy. So lenalidomide is still a consideration for, we're talking about what's available in the real world. And I'm sure all of you are so creative in trying to find the right option. I think for the right patient, lenalidomide is still a consideration. The other immunomodulators, the CellMod, I think we are looking at considering those combinations in the near future. It's a better form of lenalidomide. So definitely checkpoint inhibitors, as I showed you our own data, I think when combined with the HDAC inhibition or with AZA, even Enrica Markey at Charlottesville has a study of the PD-L1 inhibitor with romidepsin, and it's shown responses, particularly in the TFH subtype. So immunomodulation is perhaps going to play an important role in TFH subtype.
Right. About brentuximab, you mentioned about various cutoffs for CD30 positivity. So finally, what is the take? Is the percentage positivity important, or just any positivity will do?
So the emerging data is that any positivity would do. Of course, ALCL is not a problem because 100% of them express CD30. The other subtypes for the PTCL-NOS and the AITL, it appears that the cutoff does not seem to matter. But I also think there's more to it. And I think when you combine it with chemotherapy, it perhaps needs a little bit more elaboration, meaning that you might need to add other agents. So brentuximab alone may not be sufficient, or take a maintenance route with brentuximab. It's even Dr. Michel Fanal's data before this E2 was designed was a maintenance study, and BV seemed to make a difference in those patients. So in other words, the cutoff and our latest data is the SGN 32 study. It's an international study. We have about 79 patients, but what we showed at EHA is that the cutoff, even less than 1%, does not make a difference. Of course, this is a FDA commitment study, but I think if you don't have anything else and BV is the only thing that's available, it's definitely a consideration.
You mentioned about the studies where brentuximab was used upfront in combinations and then in maintenance. How is the tolerance if you used it upfront, then to give it in maintenance to the problem of peripheral neuropathy come in the way?
Yes, absolutely. Absolutely, it's a problem, particularly for older patients, but for diabetics, and transplant adds another element of enhancing the neuropathy. And we've had patients who are just barely able to complete anywhere from 2 to 4 post-transplant brentuximab because of that reason. We also had off-protocol patients developing, a couple of patients developing Guillain-Barré syndrome. So it is a problem. I think you have to be very careful about that. Though the original study was designed as 6 + 10, so the total of 16, which is the original label for brentuximab. But in reality, they may not tolerate that, and you may have to do a lot of dose reductions. And so, of course, that's a clinical call. That's in that scenario. The real question is how much dose of brentuximab is important. When you look at a long-term tonic approach, and we have the study with radiation and MF, I think 0.9 seems to be good enough. In other words, you don't have to get to 1.8 in many patients, and some of them have a body surface area that's pretty big where you cap off the brentuximab. So clearly, it is a huge problem, and unfortunately, that's an area we're not paying attention. We use Neurontin, we use Lyrica, but peripheral neuropathy is a big problem.
If there is a T-cell malignancy near dura mater in the epidural space, are there any specific recommendations for CSF examination or prophylaxis or radiation?
Yeah, so one good thing in T-cell lymphoma, unlike B-cell lymphoma, there's this whole brouhaha on whether to use high-dose methotrexate or not. The risk in T-cell lymphomas is smaller. It's less than 1%. But these are exceptions, and the epidural area is still a parameningeal focus. So we would still take the traditional approach of doing a lumbar puncture is helpful, but if it is in the dura mater, especially in the cranium, then I think a different approach might help. I think we have to extrapolate the data here. If you use, if that's the only site of disease, then you would use a high-dose methotrexate-based approach and sort of do a de facto de Angelis approach without the Rituxan. If it is part of the systemic disease process, then you could consider using a high-dose methotrexate towards the end and maybe give intrathecal. We have not given up that approach of doing intrathecal methotrexate or high-dose methotrexate, even though that's the retrospective data on the B-cell malignancies. T-cell lymphomas, the problem is, even though it's less than 1%, even if it's epidural involvement, these patients don't do as well. The outcomes are very poor compared to the B-cell counterparts. And of course, you always have radiation in the situation to consider.
In advanced stages of mycosis fungoides, how much is the utility of interferon-based therapy, and how do you compare it with photopheresis?
Well, it's actually a great question, and I think we have not given up on interferon. Interferon has helped anywhere from stage 2B to stage 4 and particularly as a first-line therapy. The problem is we don't get interferon. Merck withdrew that from the market without any data, and patients were doing fine. When they're able to tolerate interferon, it's perhaps one of the best immunotherapies you can think of, both for ATLL and also for mycosis fungoides. When we do interferon and when we do photopheresis, both are immunomodulating approaches. Photopheresis is gentle, and so we try to combine. So for the right patient, if it's very early stage disease, let's say stage 2A, or also has some circulating caesary cells, you could consider interferon. But if there's erythroderma and if there's a lot of caesary cells, the consideration for combining interferon with photopheresis is reasonable. Of course, now for caesary, one of the reasons why interferon has fallen out of favor here is that for caesary, you use mogamulizumab. Mogamulizumab is perhaps the best way to clean up the blood bone marrow compartments. And so in that situation, mogamulizumab has taken over as a therapy of choice for Sézary syndrome. And you can still do photopheresis for a limited period of time, but you start tapering out the photopheresis after a point. And it also depends on what the economics of using mogamulizumab are, because it's an expensive treatment. And so in other words, interferon has fallen out of favor. We are now using PEG interferon, which is the Pegasus, is one formulation. The other one is ropiferon, which is also approved in the other MF, which is myelofibrosis. But it's very hard to get. Of course, it's an insurance-based system. We struggle with getting approval for these patients.
Mycosis fungoides and Sézary, are they part of the same disease or they're different diseases?
So they are the same spectrum of the same disease. The biology changes, and I think it all has to do with the trafficking of the T cells when it goes beyond the skin compartment. They acquire features that enable it to survive in the extracutaneous compartments, in the blood and also in the viscera. So you can think of it as a spectrum, and it's the rough analogy is SLL and CLL, but it's the same disease. But when you do see disease in the blood and the viscera, you treat them very differently. If you only have MF, you may not use moga, because mogamulizumab doesn't work in the skin setting as well as it works in the blood compartment. And so the support structures there, the immune modulation there is very different. So I think even though it's sort of the spectrum, the biologically what they depend on is very different.
And what's your first line of therapy for Sézary?
Sézary is mogamulizumab. The first line of treatment for anybody with a high white count, as long as they have no transformation. Sometimes with Sézary, you can also get large cell transformation, and mogamulizumab sometimes can worsen the disease process, and there is some biology considerations there. But our first choice is mogamulizumab. You can also do photopheresis in lieu of getting the mogamulizumab. You can start the photopheresis. You can do it, 2 or 3 times initially, and then go down to twice a month or once a month eventually. But mogamulizumab is the treatment of choice. Of course, we also tell the patients to spend some time in the sun, about 5 minutes, 3 times a week. So these are all some of the immunomodulatory approaches that we ask, we're able to do.
Thank you. Sorry for bombarding with so many questions.
No, absolutely. These are all questions that we face day in and day out. So these are all well within what we do, and much more so. And I realize, Dr. Agarwal, that you see a lot of T-cell lymphomas, and if there is any way we can collaborate, and I think there's some efforts. I think Dr. Salvia Jain is doing some things with certain centers in Mumbai. But we would love to perhaps collaborate even with some data sharing, and I think one of the areas I've mentioned, which we didn't talk about, it's a whole different talk, is take just simple pathology slides, and convert them into digitized images, and we look at the imprints, and we are able to tease out many aspects of the biology just by looking at that. Of course, we have a data comparison with a rich data set, which involves genomics and immunophenotype and everything. The advantage of using deep learning is that it learns quickly from that, and it's able to predict what might be the genomics in this situation. So in some ways, it's a poor man's genomics, if you will. And if there's a ways to do that, would be very happy to collaborate with you on that.
That's fantastic. Well, thank you. That was the last question from my side.
Thank you. That was wonderful. We have some questions from the audience. Dr. Krishnanathan Kannan wants to know what is the role of ALK inhibitor in case of ALK positive anaplastic large cell lymphoma?
Fantastic question, and we didn't talk about it. Yes, there is definitely a role for relapsed ALCL. So that's another subset where we do see when they relapse, they don't do so well. And in some instances, it's usually the pediatric end of the ALCL, because there's a bimodal. There's an ALCL pediatric and there's an ALCL adult, which are ALK positive. And many of these patients do end up getting an ALK inhibitor in the second-line setting. So crizotinib is the only approved agent, even though it's not an easy drug. A lot of our oncology colleagues have great experience using ALK inhibitors. The preferred choice is alectinib. Alectinib is much better tolerated. And many of these ALK-positive ALCLs, when they relapse, they also relapse in the CNS. So alectinib also has CNS penetrance. So, and there's, of course, a Japanese phase 2 study showing that alectinib shows a high response rate. So definitely for second-line setting, particularly when they have received brentuximab, I think ALK inhibitors is probably the only way to go. Having said that, ALK-positive ALCL in the adult behavior is very different. The general saying is that they respond even to holy water, which means they are very sensitive. So the biology is also important, and you even treat them with single agent brentuximab retreatments. Sometimes they also respond. But for advanced stage disease, for CNS involvement, I think ALK inhibitors in combination with chemo is perhaps the way to go.
Thank you, sir. Dr. A.K. Ganju has a question. Is CAR T-cell therapy FDA approved as of now?
No, it is not. It's still ongoing studies. CD70 is an allogeneic CAR that I showed, but there's also the CD30 CAR, which didn't show a whole lot of efficacy, neither in Hodgkin's nor in T-cell lymphomas. There is a bispecific CD30 that is being developed. We are doing that. There is also a CD30 with a different construct with camptothecin derivative, and also tweaking the linker. The other targets was for CAR T or autologous CD4. CD4, we did a study for CD4, and it appears to be helpful, not so bad as we originally thought. It's not like Campath where it gets rid of everything. There is a prolonged lymphopenia. The CD5 CAR, we are doing a larger study now in the next coming months, starting in January. And it's in collaboration with Baylor across the street with March Bio. And there's also the CD7 CAR. So we have found ways, as I told you, it's a pan-antigen, pan-T-antigen, but we have found a way to preserve the normal structures and without destroying them. So it's not FDA approved, but there are still ongoing studies.
Thank you. Dr. Mohammad Rifai is a case of CD8 positive epidermotrophic aggressive T-cell lymphoma, residual disease even after 6 cycles of CHOP. How would you proceed further?
Yeah, so of course here, the first choice would be the CD94 study, because CD8 positive epidermotrophic T-cell lymphomas have this. The question is whether it's cutaneous or nodal or exnodal. But sometimes the cutaneous varieties have the JAK fusion. So JAK fusion, they not respond universally, but they have a unique predilection to JAK inhibition. So if you have Jakafi available, that's a consideration. The problem with the JAK inhibition with Jakafi is that it is the pharmacology is not very ideal. It's a short-acting drug, and you need to have prolonged suppression of the JAK activity. So there are also reasons to suppress JAK1 over JAK2, which the Jakafi does not have those capabilities. But I'm sure there are a lot of other JAKs, and we've used off protocols such as the baricitinib, which has been approved in COVID settings, right? So I think that's available even in India. So I think those are some of the things in these CD8 positive epidermotrophic, if it is cutaneous particularly, but I would combine it with the chemo. And now we are going to report our experience with Gemox with Jakafi. Very well combined. There's not much side effects with that. Of course, it's a case series. So if for this particular patient, I think I would do a Gemox with Jakafi.
Thank you, sir. Another question from Dr. Hitabi. What is your regimen of choice for T-cell lymphoblastic lymphoma at MD Anderson?
So they are all treated in the leukemia protocols. Dr. Kantarjian's group started the nelarabine. Dr. Gautam Borthakur started that approach. So nelarabine is still the choice for frontline setting with hyper-CVAD. And now Nitin Jain has tweaked that and added other agents, including L-asparaginase, the peg asparaginase at some point, and also using Velcade. In some ways, using agents that are very active and a kitchen sink approach of combining this. I don't think we have an open protocol as yet in T lymphoblastic lymphoma. So if patients come in, they start off with an elarabine hyper-CVAD approach, and then you start adding other agents based on the responses in the first 2 cycles.
Thank you, sir.
And of course, take them through an allogeneic transplantation.
Thank you, sir. Another question from Dr. Shyam. He has a case of ALK negative ALCL with a very high Ki67. He presents with an isolated cranial bone single lesion. How would you treat this patient?
And if the patient has received prior BV or not, that's the question. If the patient has received BV, you can still retreat them, rituximab, and you can combine that. And so if it's a cranial lesion, so I would take that as a bone lesion. So one of the things you can consider is combining BV with radiation. So, we have done that in the MF setting. We have an ongoing protocol. And of course, our radiation oncology group, they just do hematology. So there's a lot of experience. And I think Dr. Dabaja, Botena Dabaja, is part of the, co-founded the ILROG group. I am sure there are several folks in Mumbai, which are also part of the ILROG group. So I would, if you need any help from getting the protocols for the skull, I think we'd be happy to do that.
Thank you, sir. His another question is, would you recommend adding frontline brentuximab combination chemotherapy for every newly diagnosed CD30 positive ALK negative ALCL?
Yes. For ALCL, there's no question. Yeah, for ALK positive, ALK negative, no question, it's CD30 positive. The exceptions are cutaneous, right? So if you have cutaneous ALCLs, you don't need to treat them many times. They may appear more dramatic than they actually are. It's a sort of, if you've seen cutaneous ALCLs, it's almost looks like an alien that's coming out of the hand. And then they just drop off and then it just come in crops. Some of these patients can be just treated with single agent brentuximab. So that's the exception.
Thank you, sir. And the last question from Dr. Hita B. She wants to know about what is the treatment for adult T-cell leukemia lymphoma, ATLL.
Yeah, so there is no consensus, at least in the US. We don't see as much, and I'm sure, I understand that you are seeing quite a few in India. The approach is to use CHOP, EPOC-based approach, and the Japanese consideration is to combine them with mogamulizumab. The best responses, even in older patients, I think there's a Lugano presentation on patients over the age of 65. They combined CHOP with mogamulizumab. The responses are better. They tolerated better. It did improve the overall responses. It didn't improve the overall survival. But I think the right approach is to see if you can get moga and chemotherapy, EPOC-based approaches, and try and get them to an allogeneic transplantation. Of course, this is for the leukemic variety. And especially when they have cells in the blood circulating, when they have starting to have high calcium, you need to give them high-dose methotrexate. You need to also do intrathecal chemotherapy because there's a high risk of CNS relapse. If they have indolent or chronic type ATLL, it's a little different. I think you can easily treat them with high-dose interferon if available, and that's the original data from Miami where I trained, where we saw a whole lot of ATLL. And combine them with AZT, azithromycin at 600 milligrams 2 times a day, and interferon, 5,000 international units, IV, not sub-Q, every day for the first 2 weeks is an induction part, and then there's a maintenance part. So that would be the way to go for some of these patients. You could also consider doing sub-Q in the indolent varieties for ATLL. Now we are substituting AZT with Biktarvy. Biktarvy is the other protease inhibitor that I think has also helped HIV, and I think work done in New York in Montefiore. I think we have substituted this AZT for Biktarvy. So these are some of the things that I would do. There's not one answer. For the ones who just have HTLV, I think when they go to a blood bank and get the serology testing done, or family members of those with ATLL, I think you just need to watch and make sure they don't progress into any form of ATLL.
Thank you, sir. I've finished all the questions from the audience. Any discussion has any other questions? Sir has a question.
No, just a comment that we are fortunate in getting PEG interferon by the gastroenterology division of Zydus in India.
Oh,
They
fantastic.
originally brought it for the gastroenterologists for hepatitis infection. Of course, the demand over there is zero, but they've continued it and we have it. And in polycythemia vera, it's a disease-modifying agent today. So some of the patients have started using it as well. So that way, we have an easy access to the compound. And my last question, and the last question is about Jakafi in HLH as the presenting feature for T-cell lymphoma. So would you use it upfront straight with the etoposide?
Great question, Dr. Agarwal. So we have done it. The problem with the RUX studies that were done in China and the experience in the lymphoma-associated HLH is very different. Perhaps the numbers of T cells that get provoked in malignant HLH is very different. In the other situations, in the secondary HLH from other reasons, EBV particularly, numerically the T cells are not that much. So I think RUX seems to be able to control this. In fact, the study from China in pediatric HLH was to use RUX for the first month and then add chemotherapy, RUX with steroids, and then add etoposide, and then add other chemotherapies if necessary, and the response rates are pretty high. Majority of them are EBV-associated HLH. In lymphoma-associated HLH, it's a very different story. We have used, so etoposide dex is very important. We have also used ruxolitinib, and it helps ALCL. ALCL is the only exception where RUX seems to make a huge difference because it also targets the disease. It also targets the HLH process because after all, the ALCL hyperactivation is through hyperstat pathways. In other entities, RUX has not seemed to make a difference, but we have given it. We have given it with the combination that I just mentioned. Gemcitabine is a good second-line therapy for HLH. So we have combined Gem-Ox with a Jakafi, and it seems to have made some disease control, but we really need clinical studies. We have emapalumab. Emapalumab has made a difference in lymphoma-associated HLH. I don't know if it's available in India and if it can be made available in India. And then now we have the other approaches like the PanSERP. The do not eat me inhibitor is potentially one of those targets that can be expanded to treat these patients. So RUX, yes, I think you can use it. It may not be sufficient except in ALCL.
Thank you. Thank you so much.
So any other discussions want to ask? Any question for Dr. Iyer? Well, sir, you want to say something more?
No, it's your ball game. Continue.
Thank you. So, sir, I finished all the questions from the discussions from the audience. Sir, I must say you're fantastic. What a brilliant lecture you had, and what a wonderful discussion. It was so flawless, and it shows your volume of your knowledge. And I was so fascinated with the way you were talking about whatever questions were asked. Immediate answers were coming from you. Thank you so much for being with us. We had a very, very great morning, and thank you for being with us today. Well, thank you so much. All the discussions, thank you so much for being over here. And meet you tomorrow with another fantastic webinar tomorrow at 11:30 a.m. tomorrow, Sunday, starting at 11:30 a.m. Well, thank you so much. Thank you, Agarwal sir, for giving me this opportunity. And thank you, sir, for joining us today once again.
No, thank you for your kind words, Dr. Agarwal. And I happened to meet him at Lugano, and that's when he asked me to do this. But I really am so happy to have this interaction. You know, T-cell lymphoma is a lone group, feel lonely. And we look at B-cell and everybody is enjoying that. And T-cell is, like 10 people standing on the side. So, but thank you for indulging me today. And I think it's a very difficult disease, and more questions you ask, it's better for us to improve outcome. Very much.
Thank you. Bye-bye. Have a wonderful day. Bye.
Thank you. Okay.
Thanks.
Bye. Bye. Good night.
Good night. Bye.